Are you prepared for delivering the anticipatory care as part of the Primary Care Network DES and IAF indicators? The indicators are live now, so join us this morning as we review what primary care networks and practices need to be doing to prevent avoidable admissions right now. Let's go. We're live. Good morning, Andy. How are you?
Yeah, I'm good, mate. Yourself?
Yeah, not too bad. Yeah, quite looking forward to the discussion today. This is one of those topics where there isn't that much written about it already, so we can talk and think about how anticipatory care might best be deployed across our primary care networks and across the system. Because of course, this isn't just about primary care networks. So yeah, how about yourself?
Yeah, taking on the last couple of days of Ramadan, so looking forward to being able to have caffeine in the daylight hours again. Definitely for that. But in terms of, I guess, this episode, we've got, obviously, you mentioned the anticipatory care DES that we're looking at. And just a reminder to all of our EGP learners that this is not about palliative care. It's the confusion that me and Andy always end up having and stuff. And we have to remind ourselves about this. But yeah, it's about trying to look at and prevent hospital admissions and complications of conditions for patients. And we liken it to the unplanned admission DES is probably the best way of describing it for those of you that do remember that from a few years back during Jeremy Hunt's time, who's had a bit of a renaissance lately, hasn't he?
Yeah, I know we're beginning to speak about him in more positive terms on the podcast of late, which is interesting.
Mm-hmm. Anyway, shall we have a look at the DES itself? Because I'm sure.
Yes, if you bring things up. So as we've alluded to, this is about basically reducing admissions to hospital where they might have been prevented. Had the patient's needs been anticipated better. So we're sort of looking at two broad categories of patients and disease. Really, it's people with long-term conditions where better management of those conditions might prevent deteriorations and then admissions to hospital. And then also those patients where they have an acute illness and kind of more timely or more effective access to primary care might prevent the deterioration of those acute illnesses that could be treated earlier in the course of the disease, but they go on for longer and require an admission. So it's really about those rather than, as you say, palliative care. This is referred to in two places, really, in the primary care network literature. So the document we've got up at the moment is page 61 of the main primary care network direct and enhanced service network contract. And it's dealt with here, and it's also dealt with in the IAF requirements on page 48, and we'll look at that as well. This is worth 111 IAF points to primary care networks. So if an IAF point is worth £200, and there's lots of times when an IAF point might not be worth £200, but if we take that as the figure, then this is worth about £22,000 for an average size primary care network, which is quite a considerable sum of money, really, and a considerable resource to kind of invest into this intervention.
Absolutely. So, I think it's important to remember that it's one of the largest cohorts of the IAF fund, so it is quite significant, as you mentioned. And just for our people that are joining us live, so I have put the link to this particular document in the chat, so if you did want to click on and join us looking at it and stuff, welcome to do so. As Andy mentioned, it's page 61, as you can see there.
Yeah, and really, really would welcome comments this morning, because this is an area where systems and primary care networks are going to be left to decide what the interventions are. So really, really keen to know if people have had experience of things that have worked to reduce unplanned admissions in the past. I know we've tried a number of things locally, which we'll be talking about, which haven't always been that impactful in this area. I think it's a really difficult nut to crack. And also just if people have just general comments or concerns or positive things to say about these things as we go through. So let's have a look at the DES and what the DES says. So essentially the DES is saying that the responsibility for commissioning anticipatory care is with the system. So a lot of the responsibility here is with the system to engage with the primary care network, and also to pull in the other partners that are going to be required to effectively address this problem of unplanned admissions, into the conversation. So it's the ICS has a lot of responsibility here. PCNs have a responsibility to contribute to the development of this ICS plan. And the plan, so this part of it actually is to be sort of planned and agreed within 2022 and sort of implemented in the next year. The IAF interventions, they should be starting right away, actually. But the component of the DES talks about this year primary care networks engaging in the planning for the joint delivery of anticipatory care interventions. And then it also sets out a general sort of framework for the plan to take, and we'll be using this as the basis of our discussion a little bit later about how we might implement these things. And then, as I say, the intention is to put in place something that goes live from the 1st of April 2023. So that's the requirements within the DES.
Mhm.
Any thoughts on that, Gandhi, before we move over to IIF, which is the more timely part of this, I think?
I think it sets out the plan for what's happening in the year to come, and I think part of the thing to many people may then get sidetracked with is because a lot of the other stuff that we have to do is specifically for this year. They may lose a little bit of focus on doing this because it's a bit more ethereal, it's a bit more tricky, it's a bit more engagement based and stuff. So it's just not forgetting that you have to kind of do this preparatory work and stuff. So making sure that people don't forget that, because otherwise they're going to have real challenges next year. And as we mentioned, this is a significant number of points on the IAF, so it's not something you want to really lose out on. But yeah.
Yeah, absolutely. And you need to be banging on the door of the commissioners if they're not banging on your door to start the
Mhm.
development of this plan. I think we started to have some conversations in the kind of county-wide PCN clinical directors
Yeah.
group, just
I
beginning
remember
really.
when this came out originally back in October when they gave us more details. I've been saying for 6 months that this is one of the key parts of the PCN DES outcomes that themselves cannot do independently. They have to work with other people. And interestingly, now that we've had more details as to what we're meant to be looking at, we still don't have any of the data, and we're going to come to that when we talk about the IF part, how important the data is going to be in terms of tackling this particular thing. So without that engagement from the system, you're really, really going to struggle to achieve this.
Absolutely. So probably time for us now to just switch over to the IAF document. So this is the main updated new guidance for the implementation of the Investment and Impact Fund for Primary Care Networks. And this talks about something that we need to be doing this year
Mhm.
going forwards. So there are some live indicators for this. So it's AC 02 and 03 that really set out the rules for this. It's a composite quantitative index. So Gandhi, just explain what that means. I think you explain this better than I do.
Okay, so yeah, we did cover this in the IAF episode, which I did a week or so ago. And if you do want to watch or listen to that, feel free to go do so. It is an hour and a half long, but it's everything you need to know about the IAF in effect. But a composite quantitative, so quantitative means it's numerical, so looking at change, and composite basically means change from your baseline from previous years. So you do need to have the previous year's figures to look at this. So you'll need to establish what those are, and then it's based on rate of change from your composite. So it's not based on an actual reduction based on just pure numbers. It's based on what you've previously done. So in that respect, clearly fairer than just a blanket approach of you have to do 20% reduction or something like that, because it's based on what your existing numbers are. And it's a shift change from that. Although we still struggle to understand the threshold, didn't we, Andy?
Yeah, we'll get to where it represents the threshold at the moment, and just sort of taking it at face value gives a figure which I don't think is right. So we'll have a discussion of that when we come to
Mhm.
it. But if anyone has got their head around this already, then please let us know your understanding of the thresholds. But I think actually because the system is going to be so involved in setting the baseline that really some really good engagement with those people who work in data analysis at system level in your area is going to be
Mhm.
required to understand actually quite how many patients you're going to be needing um, uh, to avoid an admission for in order to make an impact. I don't think it's going to be very difficult to reach those conclusions without the input from those people. So
Mhm.
let's just sort of continue to scroll down. So this box gives us a bit more detail about what we're trying to achieve. Um, so essentially, the denominator, I believe, is the number of admissions in the categories, and we'll come to those in a moment in the
Yep.
previous year. And the numerator is this year's achievements or the year in question that you're looking
Mhm.
at. And they're talking about these thresholds for reduction. So I was reading this as an absolute reduction of between 0.8 and 1% of these types of admissions. Although that feels like quite a potentially a low number. It feels like a good year in terms of flu, for example, or
Mhm.
other factors that might be seasonal might move this figure by that amount. But then I might be wrong.
Mhm.
Did you have any deeper understanding of that figure, Gandhi?
Not at all. I mean, we talked about this earlier, and we're a little bit confused as to what these reductions actually mean in terms of numerical amounts and stuff? Because it kind of seems the opposite way around as well. You would assume that they want a bigger reduction as the upper threshold and a smaller reduction as the lower threshold. And how does that look and work? And yeah, it's a little bit confusing for us. Maybe the
Yeah.
decaffeinated brain part of that, but yeah.
Yeah. So, but I guess what this indicator is looking at, it's basically about numbers as we're
Mhm,
talking. So, it's about there's a number of admissions one year. We're trying to reduce that next year. So it's not really about telling us what we need to do. That appears to be the thing that we need to work out for ourselves
mhm,
in order to achieve this. This one is purely just setting us a numbers goal rather than an activity goal. So let's scroll down and just look at the sorts of cases. So in terms of defining avoidable admissions. So these are
mhm,
admissions where anticipating it ahead of time, or better management ahead of time might have made a difference. So there's group one, which is about effective long-term management. Group two about rapid primary care response to an acute presentation. Just scrolling down because I think here we go. This gives us an idea of the sorts. So these codes are a bit unfamiliar to me. I think these are hospital codes. Is that
mhm.
right, Andy?
Yeah, so it's hospital. If you just scroll up, I can't remember the exact term. Hospital.
Is it down here?
No, it's at the top, a bit higher up.
Sorry, I'll scroll upwards, Andy.
Keep going, keep going, keep going.
Hospital
There we
episode statistics.
Yes. So, finding this data out is a little bit tricky, to be honest, because it's not like there's just a big, massive spreadsheet that has all of them on. There are spreadsheets that have them on, but not all of them. So, we've been able to decipher a couple of these codes for you. So, for example, J20 that you can see there under the COPD diagnosis is acute bronchitis.
Okay.
And J41 and 44 are weird codes that kind of match up to also bronchitis, but under weird and different names. But if we scroll down a teeny bit, we come to the ENT codes, which is in the group two areas. So these are the ones that could be prevented potentially by primary care doing a little bit more from their perception. H66 is suppurative otitis media. And interestingly, they don't count H65, which is non-suppurative otitis media.
Hmm, okay.
So it's a bit weird this way. So it's interesting when you start looking at some of the codes. Unfortunately, we've not been able to decipher all of them yet, but hopefully we'll be able to do that for you so we can give you a list of what these actually mean. But to be honest, you're probably going to need to speak to your local commissioners and the hospitals in particular, because one of the things
Yeah.
we realize a lot of this is going to come down to coding.
Mm. Yeah. So, and just for people listening rather than watching, there's not a great number of conditions in these groups. So I'm just going to go through them really. So in group one, so these are things that are amenable to better, effective long-term management to prevent admissions. So we're looking at asthma codes, and I think
Hmm.
with these codes, they're just an effort to really just encompass all of the codes that an acute deterioration that's preventable might
Yeah.
manifest as within hospital coding, and I think that's the objective here. And they're
I
probably just
loved
including.
J46. J46 is status asthmaticus. I can never remember ever seeing that code down written down. But yeah,
Sounds like that'll be an ITU to me. Yeah, so I think they're just trying to encompass everything that might capture relevant data within the hospitals. So we've got asthma, we've got
Mhm,
congestive cardiac failure, there's diabetes complications, COPD, hypertension, um, interesting one.
mhm,
And convulsions in epilepsy. So those are the long-term condition-related ones. And then in group two, so these are things where we might have intervened a bit sooner to prevent an admission. We've got influenza and pneumonia,
mhm.
pyelonephritis, cellulitis, and ENT infections. And it's interesting. There's these codes that are excluded as well. I'm not quite sure
Mm,
how that works, but it's definitely one where this is hospital coding, isn't it? So
yeah,
it's dependent upon the system to give us this data. I don't know if we've had our baseline data this
not
year,
yet.
given we're already in the year when this will be measured.
Mhm. So I think
I
this is
don't.
one action that most networks and particularly clinical directors need to be looking at right now is you need to be contacting your local area teams and basically saying to them, we need the data for 21, 22 because we need to know what these are so we can start tackling what the significant challenges in our area and also composition based on local versions versus national, I think, or regional. In terms of what does this look like, because then actually that gives you a comparative area of where there may be outliers and where you potentially need to focus on more significantly. And also, hopefully, then that gives you opportunity to learn from other areas in terms of what are they doing differently. That means that you have, um, you know, different figures, better options and that kind of stuff, and how they're achieving them.
Of course. And as you say, it's very reliant on hospital coding as well. And I remember when I was a slightly younger GP, more senior colleagues used to um, suggest that sometimes things are overcoded in hospital, and I'm not
Mhm.
sure whether that's the case or not, but that relates to an element of how hospitals are paid, and there's potentially incentives within the system to
Mhm.
overcode or code for multiple different long-term conditions when only one of them has landed them there. So that kind of thing, I guess, needs to be addressed as part of the system's response to that, if that is still a problem. And I'm not saying that it necessarily
Mhm.
is, don't want to get in trouble with secondary care colleagues too much, but it could be an issue.
Mhm.
So those are the requirements really. So we've got quite a lot of freedom in terms of how we address this area of IAF that's worth
Mhm.
111 points. So I guess we should talk about how this might be implemented, I guess.
Mhm.
So I'm just going to return to the DES because actually this framework provides quite a good way of thinking about it, I think. Um, this is what the system needs to engage in a conversation about, but you could
Mhm.
have a mini conversation about this within the primary care networks,
Yep.
I think. And I suppose actually just another thing to say just before we start, this feels like a really big challenge, and it is an absolutely enormous challenge. And I'm not sure I'm aware of people making a huge difference in a sustainable way on this in the past, or not without Herculean effort. But there's quite a lot of synergy between this and what primary care networks are already doing and the resources that primary care networks have. So, we will all be already doing other things as part of other IAF indicators and DES activity around CHD,
Mhm.
um, case finding and tackling CHD factors, supporting patients in care homes in increasingly effective ways. Hopefully, and a lot of these admissions will come from care homes, I should imagine. And we're doing targeted structured medication reviews for patients, just as a few examples.
Mhm.
And a lot of the resources we have is primary care networks in the form of our clinical pharmacists, for example, might lend themselves quite well to this sort of work. So I just wanted to highlight that. And there's also the synergy between what the ICSs are required to do and what we're required to do for the
Mhm.
IAF, which is the bit that we get paid for. So that's something that's different potentially to when we did things like the unplanned admission DES before. So maybe there's hope this time. So
Yep.
I just think about this framework, and where would you start, Gandhi, in
Well, I
terms
think
of
you
doing
have to
something like
start at
this?
the beginning, don't you, Andy? So that, that first part of how to identify the population cohort which will benefit the most from proactive care in the community. So, getting an idea of what your baseline data is. So we've already established that's going to be a really important part of this process. And that's something that networks need to be doing now, to be honest, really banging on the doors of their commissioners and saying, look, what is the data for our local area? Because it's going to take time for that data to come through. And then having some comparison of that versus the national picture and what does that look like. Now, interestingly, the national data comes out in September. So that's really annoying because, the national based data we're not going to have till September to even start considering how to tackle and look at that. So to me, that shows a real failure of the system at looking at data and that kind of stuff. But hey, it is what it is.
Yeah,
Um, so what does that mean? And like I said, what are the areas that you need to focus on in your particular area of tackling elements of health inequality? So you mentioned about how, a lot of the IAF criteria blend over into other areas. There is the Health Inequalities Initiative, and that's part of the IAF as well that networks need to be looking at. So how does this relate to those health inequalities? Is there particular populations where, talked about the Pareto principle, I think it is, where small amount of impact has a huge amount of gains on particular populations. Well, this is the key thing of that. It is, looking at by having a shift change in 1 or 2% in one of these particular clinical areas, that can have a multiplier, compound effect in terms of how that works in terms of admissions for particular other things. So, is it that you create an acute hub for your local patients with asthma and COPD exacerbations where they are seen directly without having to go to, necessarily interventions with the practice, and can be assessed by, PA workforce or paramedic workforce or, those kind of services for your local area, collaboratively created between yourselves and secondary care, that then helps to prevent exacerbation so that patients can get access to their treatments and stuff more effectively. Is it about access to inhalers, that you improve the access to inhalers in those particular conditions? Or, similar ENT diagnoses, do you look at using rapid access testing initiatives and that kind of stuff to help get a clearer picture as to what conditions need admissions and antibiotic treatments, which ones don't, to streamline that process? And are those admissions done elsewhere rather than going through the hospital services? Could it be done through local walk-in centres, local hubs, that kind of stuff? So it's looking at where those big numbers are for your area. Why are they bigger numbers, and how can you make an impact in that kind of numbering, basically?
Mm. Yeah, actually, I think you raise a really key point there, Gandhi, because there's a few different ways you can cut this. Really, you could just keep it quite broad and in the spirit of the IAF, and look kind of equally at all of these different
Mhm,
conditions, and treat everyone with one of these potentially one of these long-term conditions that might be better managed all the same.
mhm,
Or you can kind of look at the data and say, actually, asthma and COPD is a particular issue in our area, and we're going to disproportionately focus more resources on that because we feel that
mhm,
that's where we can make a difference by being concentrated in our efforts. And as you say, that might lend itself to bringing in and working together with other partners from the ICS to be much more impactful in a way that a broad approach just won't get that kind of support
mhm.
and push behind it. So there's a few ways to cut it. And when you were talking about the Pareto principle, I was thinking, yeah, certain conditions in certain areas might give you a disproportionate amount of
Yeah,
the admissions. Sometimes it's just individual patients as well. When you see
yeah.
that an individual patient is just consistently, poorly engaged and poorly managed, and they can make up a high proportion of your admissions for
Mhm,
diabetes within any single year as well. So there's kind of that patient specific patient intel level. The other thing that was just apparent to me was um, PCNs can't do this alone. Even
mhm,
the data to begin with, you need the ICS and you need other partners. So I guess there's something about actually just um, mustering the troops, so to speak,
mhm,
at the beginning, and just actually making sure that everyone who needs to be in the conversation is involved in the conversation, that they're happening, and that people are engaged with the need to address this aspect of care,
mhm,
and the potential rewards for the practices in terms of the impact on their patients, and what can be done with the additional funds that successful implementation of this might bring. So there's sort of a bringing everyone together, I think, at the beginning, and kind of
yeah,
setting out what's going to happen over the year. Are we going to have some progress meetings about this? Obviously we need an initial meeting to set the agenda, set the targets. We need to then decide what the interventions are. We need to make sure they're being implemented and so forth. So there's a process that needs to be thought about. The process of implementing the process, if you like, and then we get down to the nitty gritty. Shall we look at the next step here? So
mhm,
the next two steps really talk about ensuring that the partners, so this implies bringing the partners together, have what's needed in place to be able to share the necessary data,
mhm.
and then also to coordinate care across boundaries and breaking down boundaries. So those are two really important points. Any thoughts about either of them before we dive in?
I think it comes down to, how do you share that data effectively? So, again, if we take respiratory conditions again, if you've got patients that are attending, hospitals recurrently because they're anxious about their breathing because of exacerbations of asthma or COPD, and actually the treatment plans from are quite clear in terms of how to address these, but those plans aren't being shared effectively, and then those patients not having the treatment they should as a result of that. How can you make that process work more effectively so that actually that information is shared? So then the clinicians trust the information and the plan because that's what's been agreed and most effective for the patient, rather than going at you know unified kind of, sorry, not unified, but individual episodes of care, which then actually aggravate the situation. So, for example, if you've got a patient with complex respiratory issues who doesn't actually benefit from antibiotics, why are you then giving them antibiotics when the plan says not to? Well, if you don't know what the plan is, that's probably why. And the patients, if they're in the condition where they're compromised, that they can't explain that effectively, or they don't remember, or there's other issues around that, there needs to be a way of understanding how that information flows effectively so you can support both the patient and, impact the condition more effectively.
Mm. Really, really good point. I think for a lot of the time, we tend to think that information sharing sort of stops once everyone's signed the information, the data sharing agreement, and
Mhm,
that's really only the beginning, isn't it? And I think a lot of the success of this probably depends on actually having effectively shared care plans. So it's not
mhm,
just that everyone can see everything that's happening. It's that everybody. What would be really effective, I think, is if everybody kind of has shared ownership of a particular area, which is the care plan. What to do in these situations with exacerbations of this condition, or what is the specific plan for this condition, and everybody knows how to find that in a standardized way, because what the plan is so often is just buried in individual consultations
Yeah.
with different organizations and different clinicians, and actually bringing that together in a truly shared plan
Mhm.
would be so effective, and that can even be shared with the patient, can't it, to further increase the impact of the exercise. So I think care planning is quite key, and I think we need to be quite
It is.
creative about how we think about how we genuinely share that plan
Yeah.
and that information.
I think there needs to be that communication across the services to understand what those plans look like. So I can give you another example of a patient of ours who has episodic flares of an abdominal condition that require, they get significant sudden onset pain. And as a result of that, they end up calling an ambulance because they're in significant sudden onset pain. That's quite, impactful. And unfortunately, when it happens, oral medications don't work. We are having to consider things like injectables or other methods of delivering the medication and stuff. And the ambulance policies prevent those from happening effectively. So what they end up doing is admitting the patient to have a quick shot of morphine or gas and air or something like that. And actually, we know with this patient, just a short intervention of being able to deliver those medications is all this patient needs. But it's how can you create the process, the information sharing, the care planning, and everything that allows that to happen in a situation where, because the patient unfortunately can't self-administer those types of medications, they're not allowed to keep gas and air in the household, and they're not able to have injectable forms of morphine to use. Um, so then what's the way of making that work? And is there a way of having it so that the crews can deliver those medications? And what bureaucracy and what process needs to be tackled to make that happen to prevent a recurrent admission? You know,
Mm.
those are the things that we need to consider. And it is targeting those higher index patients that have those contacts and stuff. And how do you establish that? And we talked about the data being really important. And how do you get that right kind of data locally? Because you may have different systems outside of what other people use.
Yeah, what just struck me there, Gandhi, was again just the importance of having a fairly open conversation about this at the beginning that involves scoping out who needs to be in the conversation and involved.
Mhm.
I mean, it's really obvious that the ambulance crews are part of that transition of people from receiving care in the community and
Mhm.
receiving care in hospital, which is what we're trying to avoid, because that's not good for the system and it's not good for the patient. But without thinking a little bit more expansively about it, you might not have thought to invite those people to the
Yeah.
conversation, potentially. So I think it's just important to set yourselves up right with a good foundation and get the right people in the room.
Mhm.
And so some sort of expansion of the existing care planning that takes place, to make it universally visible and accessible to everybody.
Mhm.
Might be a really important step in this that other interventions can build on. The other thing that struck me was just being, I guess, elegant and effective with getting a lot of bang for your buck or return on the effort that you're putting in. Because I remember when we did the unplanned admission enhanced service a few
Mhm.
years ago, which was very similar, but it was just isolated to efforts really within primary care with a bit of ultimately fairly lackluster input from other community services and social
Mhm.
care, and it didn't really work very well. And I remember we had MDTs as part of that, and actually the number of people sat around in those meetings and probably the amount of resources going in was not proportionate to the effect that it
Yeah.
was having. And I think that we just need to be careful not to go down those routes again, and maybe thinking about
Mm.
how we can communicate differently outside of an MDT. They're helpful for certain
Yes.
high complex situations and patients, but to run everyone through that MDT is just a complete waste of
Absolutely agree.
time. And maybe we need to think about communicating in a more asynchronous way.
Mhm.
It just
I think
inputting
interesting
online.
points that when you talk
Go on.
about resources though, so I harken back to the fact that like you mentioned unplanned admission DES, which we've likened this work to. Important to note that the unplanned admission DES for average practice was bringing in approximately £20,000 worth of income if you were to achieve it. This is £20,000 worth of income for entire network. So actually, the funding for this, although it's one of the larger portions of the IAF, which is additional funding coming into primary care networks, and as a result of that to practices, comparatively to the work that we were asked to do a few years ago, is considerably less funding over across an area and stuff. So I think it's important to recognise that this is a good chunk of work, and it's a chunk of work that could have real system gains potentially in terms of how it works. So that's why the system partners need to be involved with it. But in terms of actual network level funding, if you compare this to previous initiatives we've had, it's not really compensatory to the amount of work that you're being asked to do, to be honest. So you need to find ways to make this work for your network, and you need to find ways to make this work for your practices. And that's why I highly recommend targeting those particular populations where you're going to see those gains and stuff.
Wise words, I think. So, and then coordinating care. So the other thing I was thinking about, there's two levels to this. There's the level of actually delivering it, and I think organizations need to coordinate on that. And when I say delivering it, I mean the patient-facing, element of this, and the care-facing element where people need to work together. And then there's just making sure that the organizations are communicating about how they're delivering this project as well, perhaps on an ongoing basis, just a few times across the year, just so that any snags can be ironed out as well. And if I was initiating this as a project, I think you need to have your eye on both of those elements of delivery. So the next bit talks about the minimum number of patients to be offered anticipatory care. It's really difficult to know, isn't it, without that baseline
You need the
information.
baseline to understand where you're going to go from there in the first place, don't you? So that's, again, why networks need to, and we're going to keep repeating this, crack on and get that data and push the commissioners and the local area teams and stuff to basically get that data as soon as possible.
Yeah, there's also a bit of an inconsistency between this sort of bigger plan, which involves the whole ICS, which is just being planned this year and will come into effect next year, and that actually we're being marked on our performance this year as part of this year's IIF delivery. So all PCNs almost need to move at two speeds with this as well, because they'll be engaging in a conversation with their ICS and their partners about things that aren't going to happen until the next year, but they need to be doing something this year. I guess it's an opportunity for the primary care networks to get ahead in a way of the other partners and shape some of what happens through having some on the ground experience. But people need to be thinking about what they can do this year as well. So definitely having those conversations with practices and getting some data ASAP, really, and some processes in place that maybe the ICS can build on later. But numbers, it's so hard. It's so hard to say, isn't it? We need the data. We need that from our partners. And then the next section after that is, how will that assessment of patient need? It refers to care planning in particular, and it uses those words. So I think that we were right to start talking about having shared care plans earlier. How those can be carried out and updated. So it's really about how is it actually going to work? Have you had any thoughts about how this could work on the ground, Gandhi?
I think, there are different ways that places could look at it. You could have a unified care plan, approach, or whatever you want to call it, a document that follows the patient around with their ideas of how their treatment works. And we saw that with the unplanned admission DES, that, we created loads of care plans for patients, and they've kind of majority of areas fallen by the wayside because there wasn't the support and the funding to make that happen. I think there are definitely options with platforms like, Arden's, primary care ITs being able to support networks by having these templated kind of documents available. Important, they can't be big. This is the first thing. This is the thing that annoys me with most care plans. They end up being several pages long. My general view, any care plan that's more than 2 pages of A4 is unlikely to be of real benefit to anybody because no one's going to look at the damn thing. So making sure it's short, sharp, and focused around the specific needs of what the treatment plans are for this patient. If you can make it digital, even better, but you also have to make sure the patient is on board with that. So how are the patient going to access it? How are the patient going to find it and use it? Because actually they're the ones that need to be able to share that with the clinicians when those interventions happen. Because as we identified, all these interventions may not necessarily be when the GP is with that patient or the practice with that patient. It could be walk-in centres, hospitals, paramedics, that kind of stuff. So that needs to be in a method that's shareable by the patient at the point of contact and stuff. If the patient's, at that point where the self-care element of the care plan is not, effective and working and things. So I think once we understand that, we'll have a better idea of how we can tackle this for most places and stuff.
Absolutely. I think there's the word sort of coordination in there as well. So I think this is something that lends itself potentially to a care coordinator role as well, if you're thinking about additional PCN resources that you can deploy above the 20,000 that you might get from the IAF achievement. Care coordinator role around this work might be quite helpful, and we're beginning to see that care coordinators might be really helpful in delivery of a lot of these things, including say the cancer care, which we'll be reviewing in a future episode as well. And I wonder if actually we're going to end up with a team of care coordinators, and actually, whilst some might specialist in one thing, actually having some awareness of each other's care load and actually operating as a team coordinating a few different dimensions of care might actually be where this ultimately goes. And actually, a patient with cancer might be admitted with a pneumonia, they're going to be more at risk of that because of their treatments. So there might be a lot of overlaps. It might make sense actually to integrate this into sort of better care coordination on the whole, facilitated by PCN care coordinators. Which leads into the next point, really. So the agreed protocol for engagement of an individual, followed by addition and then removable from the cohort list. This does sound like the previous unplanned admission letters, where we had a virtual ward approach. And I remember people got added because there was a search on eHealthscope, our local data system, for identifying people that could go on the list. And if you weren't careful, that list just got bigger and bigger and bigger, because it was much more difficult to take patients off, because that tended to be a case-by-case discussion or decision that happened. So the care coordinator would be really helpful. We were talking about managing lists. Any thoughts about that?
I think you need to be careful not to get caught into that trap of the list getting bigger and bigger and bigger and unwieldy to the point where, how do you approach that? So that's why I mentioned that I think focusing on ideally one or two clinical areas where there's the most impact for your local area. So, for example, if you work in a mining community where there's significant higher proportions of respiratory disease, maybe that's what you need to tackle, not necessarily focus on some of the other ones, because trying to do a little bit of everything may not have the best impact, it's with that focus and that target and stuff.
Comments come through, Gandhi.
Okay. Let's have a
If I
little
cut you off there.
No, let's have a look at it then. So from Facebook user, you taught us a lot about sharing care plans and getting the right shareholders around the planning, but do you have any thoughts on how that's actually done on the ground level when different organizations with the ICB system have potentially different priorities, those specifically in primary care? So again, this is where choosing the right area, I think, is going to be really important. There are going to be ICB or ICS priorities that they're going to be focusing on, and actually matching those up towards these particular cohorts would be really impactful. And the other reason for doing that is you're potentially then approaching the ICS or the system with this whole concept of gain share agreements and stuff. So actually, if the ICB priority is to reduce respiratory admissions, and you focus on respiratory admissions because of the PCN Anticipatory Care DES, actually, if you're also helping them do that, then there's a benefit to the system as well, significantly. So is there the option of sharing some of those gain resources as a result of it, not just purely so that secondary care and the ICS have the benefits, but that's shared and then creates the funding for that care coordinator role to continue doing that, not just in this financial year, but next financial year and ongoing, to have those resources. So, is that something that, again, that's why these discussions need to happen sooner. What are the priorities of the local area? What are the priorities for your network? How can you marry those up to make it more effectively and basically lead to genuine integrated care?
Yeah, I think it's such a good question. And in some ways, it's the responsibility primarily of the ICB, ICS to have those conversations with the stakeholders and to be that strategic body that aligns everybody's priorities in the right direction to make these things work. But it's really difficult, isn't it? But I think they are going to have to be creative about setting those priorities. And it's not just about setting priorities. It's about setting up the incentives that sit beneath those priorities to drive the behaviors of organizations. Because if hospitals are just going to lose out by by losing out on the money that is associated with these admissions, and if that's all that's in it for the hospitals, then they're going to be less on board. And you might have some success without them, but it'd be so much more successful if they were a proactive partner as well. I'm sure they want to be, but sometimes it's the incentives that just hold you back. So I hope that they can do something to shape the incentives as well.
And then
So-
moving on to the final area, so how the activity, experience, and impact of anticipatory care will be tracked and quality of service improved. So we kind of covered those areas partly in terms of it's the data that you need to have. You need to have a mechanism for monitoring and looking at that data and then being able to adapt and adjust it and stuff so that you can make sense of it, really.
Yeah, where's the PCN dashboard? No, could do with
This
could do
mythical
with that.
dashboard
That
we
would
keep being told it exists, but actually trying to get access and effective and useful data from it is just
Yeah, but I mean, I think the beginning is just to actually have the numbers crunched, by
Mhm,
our localities so that we can see where we were last year.
mhm,
Ideally where we are on an ongoing basis, and they need to be there to help us identify individual patients or groups to target
mhm,
as well. So I think that's a conversation with them. Although to a large extent, we've been told what we need to measure in terms of IAF.
exactly.
We're not capable. We don't have the visibility or the data to actually do that ourselves. So we need help with it. But that's what we'll
Mhm.
be measured on in the first instance.
An interesting one of the things I did find quite pertinent is so in the IIF document, it makes reference of what happens if you don't believe the data to be correct. Well, NHS England devolved this responsibility to the commissioners. They've said that you need to have a chat with your commissioners about why the data may not be correct and things. So if you get numbers that don't match up to what you're expecting or anticipating things may look like, you do need to be having those discussions again with the local teams in terms of why is this different? Why is this not effective? Why is this not really marrying up to what we think is happening and stuff? And it will be a local decision then on whether or not you have the access to the funding and stuff afterwards. And really important to be aware of that because I think this is again an area where unfortunately, from my perspective, NHS England have fallen down. This data should be available from the 1st of April. It's not. Why not? It should be universally available to all networks and stuff. And actually, if this is what the initiatives are and the plans are, a lot of unfortunately the IF and the DES outcomes are based on retrospective data that we don't get for several months afterwards, and we lose that time. And yet we're still expected to do Herculean efforts, as Andy mentioned it, to fix things. And actually, this is all down to the fact that NHS England and the systems around it don't have the data or not able to share that data with people to make it effective and timely and yet have punitive elements in terms of doing that. Is
Yeah.
that a bit cynical of me? I don't know.
Just a little bit, but it pays to be cynical sometimes, doesn't it? So,
Mm,
so I guess just before we start to wrap up, if anybody else out there has any comments, then please pop them in the chat on whatever forum or device or service you're using to view us or listen to us on.
mhm.
Particularly if anybody has any bright ideas about implementation of this or any
Yeah.
examples of things that have
And if
worked
you wanna
well.
give those ideas
Fantastic.
to us, audibly, we do love to hear from our listeners and stuff. Do feel free to use our SpeakPipe platform. So www.speakpipe.com/EGP learning. The G and the P are capitals in that. That is important. It is case sensitive in that respect. And I'll be able to let you put a recording that comes straight to us so we can have a listen and hear what you're thinking and stuff. And we can obviously share those comments later on if you want us to or not and stuff. And just like to hear from you, to be honest. Is this helpful? Is this effective? Because we know that some of this is going down really well. We've got our PCN Plus course that kicks off next week. So if you are thinking of joining us, absolutely sign up now because the course will be closing on the 5th of May for signups and stuff. And we're almost full. So you're almost out of opportunities because once people have signed up and stuff, that's it. We have got limited capacity for this time round that we're doing it and things. And that's going down really well. We're creating lots of additional resources for people who are part of that network as a part of the PCN and stuff. So yeah, feel free to jump in and join us with that and stuff. And we're obviously going to be covering more of the PCN DES outcomes in the coming weeks. So Andy mentioned about the cancer awareness part of the DES. There's the personalised care elements that you saw earlier and things and stuff. And there are other parts of the DES that we are going to be covering over the next few weeks and stuff, especially since we've got a GP5T3 conference next in 2 weeks' time. So we'll have a slight pause in terms of the live stuff and things, but absolutely we've got more content as ever coming through to help you in terms of navigating the PCN DES, general practice, technology, learning, and a few other fun things as well, don't we, Andy?
Yeah, absolutely. It's you have to make these things fun, don't you? Because if
Mhm,
you don't, it's really really grinding. So good. So yeah. So I guess my final takes on this are I think PCNs need to move at two speeds. There are things that you need to be doing things now about
mhm,
IAF, and then you need to be having a separate well, perhaps the same, but another conversation about things that are going to be happening next year on a
mhm,
grander scale with the ICSICB. And I think it's about get the right people around the table, have a conversation, and then start doing what you can this year in anticipation of doing something hopefully a little bit more grander and more effective next year, I guess. You got any
mhm.
final thoughts, Gandhi?
No, just for the Anticipatory Care DES, get in contact with your local area teams, start asking about it, prod, push, nudge, whatever you need to get that data ASAP so you can start working on it. Otherwise, trying to do this in the last 6 months of the financial year is going to prove so stressful on top of all the other things we're going to have to do as well. So whilst you've got the opportunity, prod, push, and then at least you can turn around to the commissioners if they haven't been able to provide you with that data. Well, you didn't give us when we asked it to, so how the hell can you mark us against it? That's my view. Yeah. As always, UGPNs, if you do have any comments or questions, let us know. We've got more content coming up for you right here, just about now, as usual, and stuff in terms of some of the other episodes we've got, including the IIF episode directly. And as always, we're here to help enhance your primary care and learning. And we will catch you in the next episode.
Yeah, thanks, guys. Bye-bye.
Bye.